I am going to leave the microphone here for a moment because I'm going to do a little bit of sign language in a minute, and then I'll pick it up and definitely defer to my expert interpreters over here. So my name is Kristina Petersen. I'm very excited to be here. This is the first time I've been able to come to an Ableism conference, which is amazing. I've been to a few medical education conferences where we do focus on disabilities, which has been wonderful, but I've learned so much in the last day and a half, and I'm grateful to have been invited and to be included, so thank you. To me, so you'll see on my title, I'm an associate professor of biochemistry, so Dr. Poulos, I do teach about the Krebs cycle because I'm instructed to do so. However, I also greatly value disabilities curriculum, and so this is personal for me. This is personal for me for a number of reasons. I also have a non-apparent disability, which I normally don't disclose, but after hearing this empowering talk from Dr. Lindsay, I do have a non-apparent disability. I typically have two things that I think qualify me as having disabilities, but one of them is PTSD. So I'll share that with you. I don't normally share that with my colleagues, but I know I'm on video, so this might go public, and that's okay. And anyway, I also have a intermittent physical disability, which right now is not exacerbated, so today is a great day. Anyway, I am grateful to be here. I am a professor of biochemistry, but this is personal for me. So when I moved from the undergraduate world into biochemistry, I realized that there's not disability curriculum mandated for medical students. And I was pretty upset and shocked. I guess I shouldn't have been shocked because of the state of where we are, but I was. And I decided that at first I was upset and I thought, gosh, I'm a biochemist, what can I do? And then I realized, wait a minute, I'm a biochemist who actually has a lot of personal experiences with disabilities, and I'm surrounded in this by colleagues who are physicians, and maybe I can have an influence. So I guess the other thing I didn't share is that I know sign language, and I am really grateful to my deaf friends for all that I have learned from them, and I feel very. You probably should keep interpreting. I'm not that great. I feel very strongly that we really need to make sure that we have more interpreters that are available, especially for medical appointments, because there's a shortage. We don't have enough. So I'll let you do your important work. Thank you. She's excellent. By the way, both are excellent. Okay, so I'll go ahead and get started. Normally in medical talks, we have to talk about disclosures, because of course I don't want you to think I have a pharmaceutical company that's funding me and I'm going to try and peddle my drugs or something. So I have nothing to disclose, so that's usually what I say first. And since I'm a professor and I teach, I do have learning objectives here, which is what we do when we talk in our lectures. The first one you already know, because we've talked about this over the last day and a half, communicating the prevalence, the fact that the prevalence of persons with disabilities in medical education, there's a big gap between what the general population looks like and what our medical professionals and our medical students population looks like. So that's something that we know from the last day and a half, but I will review the statistics because it's in my slide, but it'll be quick. Then I want us to focus on, I'm going to kind of piggyback on what Dr. Lindsay already talked about, but identifying barriers and ways to advocate for accessibility within medical education specifically. That's where I kind of live now, to support the full inclusion of learners and clinicians, so current clinicians with disabilities. I'd like to also talk about several benefits of incorporating, as Megan already has advocated for this morning, disability inclusion curriculum within medical education. And I'll share with you some things at our school about what we're doing and what some of the national movement is looking like. I also want to just kind of acknowledge and discuss the synergy and the importance of how all of these pieces, in terms of educational space accommodations, accommodating within the clinical space, and also making sure that patients with disabilities are receiving accommodations, and our clinicians are being trained in how to give those accommodations, how to provide those accommodations. Those are all related. And so these are all synergistic ideas, and being able to see how all these things fit together is not something that I think some of my colleagues always see. I think everybody in this room, I'm preaching to the choir here, but I just want to kind of emphasize that as my concluding point. So I'll get myself started. I know I've shared a little bit of personal stuff there, but okay, there's a lot of ableist layers embedded within the medical system. We know this, right? First, I would say, I mean, there's many I could bring up. I'm going to focus on a few. Many have covered others, which are great. So low prevalence of clinicians that actually have disabilities. This actually really does impact the quality of care that people with disabilities are receiving. I will also just mention, and it's important for us to acknowledge, that there are some people with certain disabilities that may never be represented by our clinician community. And that's because, so for example, people with intellectual and developmental disabilities, not all of them may be able to do the academic qualifications in order to go through the medical training. And so there may be some folks that are not represented, and we cannot forget those folks either. So we do want to increase the prevalence of clinicians with disabilities. We also need to think about training, because if we don't train folks in understanding different types of disabilities, particularly those that will not be represented or are unlikely to be represented in our clinician population, we're really missing an opportunity. There's also a lack of understanding of accessibility barriers for learners within the educational space, within the classroom, but then in my world, the classroom is also the clinic. And we've already talked about how the clinic is often inaccessible. It's often inaccessible to patients, and it's often inaccessible to clinicians that require certain accommodations. There are definitely ableist policies, procedures, and practices in place, and that's true in our higher educational institutions, that's true in our hospital systems, it's really true in clinics. Unfortunately, again, I wish it was different, but this is a problem. This needs to be addressed. There's a lack of training. As I mentioned, that this is one of my huge passions, and one of the things that really sort of catapulted me into really disability work and the passion that I have for it, finding out that there isn't training, for supporting patients with various disabilities. So I should also share that one of my roles already in the institution is to support students with disabilities. And so I was already sort of positioned when I started realizing that there wasn't a clinical curriculum that was addressing the nuances for patient care. I was already positioned because I was already advocating for our students with disabilities. And so I found myself with a platform, even though I'm a biochemist, to also be able to kind of expand and say, okay, we need to see how this is all synergistic, and that in providing curriculum to our students, to our students, all of them, that can also help to confer inclusion upon the folks that are in the room, who are our students with disabilities, to feel included, because they can see that the curriculum that affects or impacts their identity is being represented. There's definitely a lack of understanding of accessibility barriers in clinical care, as has been really well discussed. So this is just my slide that's sort of trying to get at this idea of synergy and the idea that all of these pieces come together and one piece supports the next, which supports the next, which supports the next. And so thinking about these different pieces, all pieces are really important to be able to bring this together and achieve full disability inclusion. So there are health disparities. I think, have already covered that. But again, preventative care is really, there's a huge gap for patients with disabilities, and health education as well. And these are just a few examples of some studies, and many of them are by Lisa Iazoni, she's a wonderful author who's already mentioned yesterday many times. Her work is so important. But she has really gone through and done some important work to demonstrate the numbers, as was discussed yesterday. What are the causative factors of these health disparities? Well, there's many of them. Physical inaccessibility is one really important barrier. Inaccessible communication, as I mentioned, there's not enough interpreters for our deaf friends, our deaf community. And there's also stigma, false assumptions about disability. This was also brought up very well. And then lack of training. Some of Dr. Iazoni's work, really she did some specific interviews with physicians that have worked with disabled patients, and they say they're not even don't always have the accessible equipment. We heard yesterday about when there's not wheelchair accessible scales that are present. One of my colleagues and friends who is a collaborator on this work, I have an acknowledgement to her later in the slides, Dr. Susan Solman, she sustained a spinal cord injury at the age of 39 and said she had wonderful health care until she was 39. And then after that, she hasn't been weighed, she hasn't been able to be transferred safely to an exam table, and she tells a story that's just gut-wrenching, but very powerful and obviously very, very important for us to consider as we're thinking about what needs to be included in training. Prevalence, we know 27% of adults have a disability. Recently, there was a recent study that was published that showed that 5.9% of medical students registered with their institution as having a disability. Now that means they disclose, right? Now there's probably more that aren't disclosing, and we do have data that suggests that there is a gap there between who will disclose when it's anonymous versus who will disclose when they know they have to submit paperwork. So we do think that there's a gap there. And then 3.1% of physicians self-reported having a disability. So we can see that there are big gaps that we need to try and fill. Now within higher education, I'll just share with you some of the conversations, I'll call them politely, that I often have to have with different colleagues. And I am really fortunate to have been invited to a number of different campuses across the nation to have conversations with different colleagues and different faculty and also students. I will say students are often our biggest ally in this work, at least in my experience. But the big thing here is that access and compliance are not synonymous. I think you all know this, but we have to try and encourage our colleagues to understand that yes, legal obligations are important. We do want to be compliant. But they're set forth as a minimum standard, really to protect against discrimination. And as we really enhance accessibility, we make progress toward full inclusion of persons with disabilities. We also have to remind our colleagues, and at times ourselves, right? We do all have ableist assumptions at times, but we need to always be reminding ourselves and others that disability really is heterogeneous. And those with the same disability will often experience different or varying barriers, and there's a spectrum, right? And of course, we already heard this from a few speakers, that the importance of distinguishing between equality and equity. Those are often issues that some faculty will push back with, and then I can try and politely explain some of the nuances that they may not yet have thought about. Also, with our colleagues, we're often encouraging people to reflect on how heterogeneous this population is, and hence, how there might be a great variation in the types of accommodations that are necessary in order to promote full inclusion of the students and our clinicians. So, depicted on the picture, we see more apparent disabilities, but of course there are non-apparent disabilities that also require accommodations that are more difficult for me to depict in a picture. Policies. We're talking about policy changes very frequently. And I'll say a lot of institutions, when there's an accreditation renewal coming up, the field is ripe for harvest, so to speak. And we can really encourage people to revise their policies and look at them from an inclusive lens. We heard about technical standards kind of briefly. These are often the barriers that are put in place to prevent or to, I see it as a barrier to prevent people from getting in, right? And it shouldn't be that way. The technical standards are meant to be, an enumerated list of different things that we're looking for in our future clinicians and skills that they will have to be able to learn as they go along. So there has been a shift, fortunately, from what they called an organic approach in the technical standards to what we now call a functional or competency-based approach, which means we want to, instead of focusing on how applicants perform the necessary skills, so in a lot of the previous iterations of technical standards, they would talk a lot about motor skills and these, more specific things, sensory skills. Taking those words out and instead focusing on what is the outcome. What is it that we actually want the clinicians to achieve? And also making specifically saying we want them to achieve these outcomes either with or without accommodations. actually having that within your policy really helps to confer more inclusivity and more value upon this accommodation, the possibility of using accommodations for example, hearing aids or even interpreters, etc. There should be an accommodation and accessibility policy, and I know that sometimes these are outdated, sometimes they're very legalistic, which can be really kind of a turnoff at least for me. But we really, in best practices, we encourage our colleagues to start with a statement of commitment, which you're committed to full inclusion. And that's what this policy, if you start with that, then we're in much better shape. Wherever possible, using less legal verbiage is important. Accessibility in the classroom and the clinic. So again, not just expressing commitment in a policy, but demonstrating that commitment and inviting students to apply for accommodations, letting students know that they are what we want them to be doing to receive the accommodations that they need. And so making sure that the messaging to our students is easily accessible, is readily available, and is, they're reminded frequently. I often ask questions, which I'll say the answers are not always very heartening in terms of what I hear. But are faculty expected to actually prepare fully accessible materials for courses? Or do they even know what that means? And often the answer is no. So I give a lot of webinars where I'm trying to teach people how to do alt text, as was taught yesterday, and other things within PowerPoint slides. Are there resources available to help support faculty in doing this? What is the accountability? And unfortunately, I will just share that, again, the answers to those questions are not always heartening. But I will say that as people learn what they don't know, I've been encouraged by their willingness to learn more. And then our facilities and classroom activities, so the teaching activities, are they fully accessible to all learners? So, for example, if I'm going to do some kind of an interactive let's say a concept, I want to do a concept map, I have some things bulleted on there, and then I want to use an electronic program to help them utilize that during a session, I have to make sure that it's accessible to screen readers. And if I have a specific student that utilizes screen reader software, knowing what that software is can be very helpful, so that I make sure I select something that is going to be accessible for that particular student. The learning environment has to be considered when we're thinking about barriers and how to address them. And of course, in our world, the medical education world, we have a clinical setting, we have lectures and didactics, and we have online things, or we have online asynchronous, pre-recorded kind of sessions. So the barriers can be different depending on what the learning environment is. And often faculty may not fully appreciate this, and so having, again, faculty development sessions in order to help our faculty understand that becomes very important. In terms of benefits of disability inclusion in medical education, we know, as has already been said, that physicians' perceptions of a disabled person's quality of life are very different than those of the experience of a person with a disability. And although no study has definitively determined how negative perceptions may influence the choices made by physicians, I would argue that anecdotally, we know, so this is a picture of my aunt with my two daughters. So the point is she has a very high quality of life and she loves her life. And her clinicians may not always appreciate that. Cultural concordance is something that we talk about in academics. What does this mean? It's basically when we say that a physician with a disability has a more nuanced approach and often has more of a likelihood to be able to understand some of the nuanced situations that are put in front of them with somebody else with a disability. And we actually see that that's true even if the person who's the clinician has a different disability than the patient. That there's still kind of this increased level of empathy that cannot be taught, or it's the empathy among our clinicians with disabilities is just so high that their patient satisfaction ratings are amazing. I will just say 52% of U.S. medical students in 2017, this was the paper that I saw that really propelled me into this, did not provide any disability education in their curriculum. And when we say that 48% did, they're usually one-off, like one workshop over a whole 4-year curriculum. And so, but people want more. Students want more. And we know that. We have seen many organizations, and listed here, that have been advocating in the last few years. So you can see from 2019 through 2022, been a number of organizations advocating for this curriculum to be put in place. There have been a number, these are just, and again, my slides are available to you should you wish to look at them. This is a number of innovations and calls to action, so I'm not saying that nothing's been done. There have been a lot of folks that have been doing really important trailblazing work. The problem is there's no curricular mandate. That's the big problem. A few of my colleagues and I have written an article that has been advocating for that to change, and many others have also, of course, been supportive of that. But there's competition for curricular time and resources, as was brought up previously, and people feel there's lack of expertise among faculty to teach sessions, partly because of what Dr. Lindsay was talking about, where we maybe don't have faculty who have disabilities, or we don't have people who are faculty members that are willing to disclose that they have disabilities. There are definitely ableist perspectives that undervalue these initiatives. And I'll just say that these concerns over all of these barriers have been expressed over and over and over again. So it's not that. So in our school, we have a universal design approach to disability in medicine, where this is kind of the overview of what we teach our doctors. And I know it seems very, very sciencey, so sorry for that. But I hope you can see where I would want to incorporate, and we are trying to incorporate, functional limitations and accommodations along in parallel with what they're learning in their curriculum. And as I was in charge of the biochemistry section of the Principles of Disease module, we call it, so the metabolism section, but we had genetics in there as well. I added a disabilities session and asked questions on the exam about it because it confers value upon it. Oftentimes, the disability sessions are kind of off to the side, or they're kind of like in an orientation, or they're an optional workshop. So by making it part of the curriculum, it's helpful. So this is kind of what our curriculum looks like. You can take a look. We're in the process actually of adding a medical ASL elective, which will focus on deaf patients as well. So again, I don't have time to sort of talk through all of this, but my slides I hope are available to all of you. I provided a PDF to the organizing committee, and I'm happy to share it. You can always email me as well. I just want to show you the yellow bars on the left are the pre-surveys. We did a pre-survey before the session, and the red are the post-survey. You can see the huge increases in knowledge in the various areas. We've delivered this curriculum now to 1,500 students. We have measured it in about 1,000. And you can see that even when we separated, so there was one year we had a 4th-year class that was about to graduate who hadn't gotten any of the curriculum because we had just created it. And we gave them and the 1st-year classes the same session. And you'll see on the left here, these are the junior medical students, the 1st years, and this is the 4th year about to graduate, literally, right before they left. And they took the same session. And you can see there's still a really significant increase in knowledge gain from our workshop. So if we had not given them that before they left, they would not have probably gotten it. And so again, that demonstrates to us the importance of this and the efficacy of it. I will just give them a little credit that there is a higher baseline. They started with a little more than the 1st-year students, but not a lot. So we have a lot of work to do. So I have some lessons learned here. Among them is the importance of data collection, the importance of tilling the soil, I like to say. So, gaining your allies, making sure that you're sort of promoting awareness and education among our faculty and among our students. And I will say again, our students are our biggest allies, at least in my experience, and so they'll often support the advocacy efforts, and having them on our side is really great. Again, putting all of these things together, the educational space, the clinical space, as well as the patient space, these are all parts, in my experience, of medical education, and inclusion in all of those spaces is really critical for us to succeed at disrupting and dismantling ableism within medical education. So we need more resources so that we can teach faculty how to create accessible content. We need more resources for technology, so some technology experts that can help to make sure that these best practices are being put in place. We need accountability for all of these things to be happening. And then also, again, as I've already said, the clinical space is also educational space. So we need to have the clinical space accessible so that not only is it accessible for patients, which I really think is important, but it's also accessible for our learners. And I want to thank all of the folks that we have that have given these wonderful interviews that really make such a difference. And I'll just say when I'm in the classroom, often I can talk and, you know, it's not, people aren't all that engaged and excited about what I'm saying, but man, when we put the interviews up, you could hear a pin drop. And that, I think, is really what makes such an impact on our students and why they're so fired up, which they are, about advocating for us to put this in place. I want to acknowledge our funders, the American Academy of Developmental Medicine and Dentistry, Dana and Christopher Reeve Foundation Quality of Life Grant, and the Alpha Omega Alpha Medical Honor Society. Thank you.